In this episode of the Nurse Practitioner podcast, Victor Czerkasij discusses difficult issues and challenges in psychiatric dermatology. Can you tell our listeners what your definition of psychiatric dermatology is?
It's probably one of the most difficult and miserable conditions in dermatology for both patient and provider. I can't give you a scientific census for that response, but I think there are very few people who have experience that would disagree with me. I've heard the phrase, "this is a living hell," both from people who are patients and those who are providers. Essentially, the definition of psychiatric dermatology, it's the interplay of or interaction between mind and diseases of the skin. We're merging right before our eyes two major medical specialties, which of course is psychiatry and dermatology. And what's interesting is that when the patient comes to either one or the other, the training and experience may not be as good in the second half of what they need. So psychiatry, of course, involves the study of mental processes, which are usually manifested internally, is really the best way I have come to understand it with my limited training and experience in psychiatry. As a nurse practitioner in dermatology, though, I'm responsible for the diagnosis and treatment of what's happening in the skin and what's manifested externally. Now we're finding out that there's a relationship or interaction that's pretty constant between the psychological and biological aspects of these diseases. In my work, I have tried to track down how far back this goes. And it's interesting that Hippocrates, one of the early Greek philosophers, he actually mentions the relationship between stress and its effect on skin in his writings. He talked about people who were tearing their hair out in response to emotional stress. Aristotle did the same. He found that between the mind and the body, they were not separate entities, but they seem to complement one another and are inseparable. Of course, if you read the Bible, you'll read today where people mention that they were under great emotional stress and they tore their hair out, which is, we'll be talking about today, an actual diagnosis that has an ICD-10 code. So we are seeing, as history progresses, this your question was, what is the definition of psychiatric dermatology? It goes back a long way. I found out in 1857 there was an English dermatologist and surgeon. His name was William James Erasmus Wilson. He wrote a book called Diseases of the Skin, and he talked about skin neurosis. So right there we have that phrase, skin neurosis, which talks about the merging of these two specialties of psych and derm. And he talked about delusions of parasitosis, unexplained itching, and he said that this might have a lot to do with the nervous system. So he was really right on the edge of figuring out some interesting things at that time.
How common is it for you to diagnose a condition that can be defined as psychocutaneous?
Well, it's still uncommon for us overall, and I'll give you an answer in sheer numbers. Once to twice a week. For the listener who wants to know what that perspective is I see about 50 patients, 55 patients a day. So now about once or twice a week, maybe 3 or 4 even, since COVID-19, we are seeing an expression in the skin that can be related directly to stress, anxiety, and depression. And that is where we are. Now, acne, of course, is our most common diagnosis in dermatology. It makes up 10 to 12% of our visits. And I will say that acne and rosacea certainly are occurring more with maskne, people wearing more masks, and it creates a perfect storm or environment to break out. But we're now seeing averaging, anywhere from 2 to 4 a week, where people are expressing anxiety and stress through their skin. So it's becoming more common. But let me put it this way. At the end of the week, if you have had one of these patients, you will remember, out of the 250 people that I'll take care of in a week, I will remember that one. So it's becoming something that we have to be prepared for because they're coming to us for help.
I understand that there is controversial history to this little-known and poorly understood area of healthcare. Can you please elaborate?
Yes, there is a controversial history here in the United States in particular. So back in 1925, there was a dermatologist named Joseph Clowder, and his name is spelled Klauder, if somebody wants to track down the rest of the story. This dermatologist wrote that there's a psychological phase of certain skin diseases that should not be neglected in treatment. And that was akin to saying the moon is made out of cheese. It was just really an outlandish statement to the medical community at that time. How could there be a psychological phase in skin disease, even in spite of the fact I told you about Aristotle and Hippocrates and others who have seen this? In fact, in response to what Dr. Clowder said, in 1927, there was a Dr. W.T. Sack. He wrote that there's scarcely a medical specialty in which psychiatry has found so little application as in dermatology. So basically, you've got two major figures in early American medical history who are having a boxing match. They are throwing these terms back and forth in a kind of a passive-aggressive way to one another as to what they believe. Clowder went on to write a book called Sherlock Holmes as a Dermatologist, with remarks on the life of Dr. Joseph Bell and the Sherlockian method of teaching. He was trying in a very nice way to establish in a professional manner that we do have a connection between mind and body. And F.A. Whitlock, another doctor, dermatologist, then wrote in 1976. Now, I'm in high school in 1976, so it doesn't seem like it was very long ago, but it was the psychophysiologic aspects of skin disease. Well, they were trying again to present this idea that most of the medical community would not have anything to do with, which was you have psychiatry, you have dermatology, do not mix the two together. It's going to mess things up. You got to either treat one or the other, but don't tell us that this crosses any kind of professional border. Well, if anybody really wants to go back to their history, in the 1980s, there was a dermatologist in the American Academy of Dermatologists, American Academy of Dermatologists. He was deemed crazy, and some medical doctors walked out of that meeting when he started to try to present that maybe some of the skin diseases that we're seeing have a psychiatric background and should be treated with psychiatry. Well, in 1991, a small group of dermatologists, in fact, it was 8 of them, which I won't go into the names right now, but some continue to practice today and are well respected for what they were doing, and I know a few. They decided to meet at the Dallas-Fort Worth airport before the American Academy of Dermatology annual meeting to discuss this taboo topic, which is the mind-skin connection. And for any listener of the podcast, I really encourage you to go to www.psychodermatology.us, which is a website dedicated to the history and the continuing study of the mind-skin connection that occurs between psych and derm today. We're still trying to understand this subject. And remember, there are very few trials and studies. And the main reason they don't exist is because we have denied it for years in healthcare. And it's not an easy topic because I'll tell you as a provider, right from my heart, it's a love-hate situation. I love to help my patients, but I hate the fact that they arrive angry. They're already terrified of what's happening. We're exasperated. They don't have time or interest for We don't have time or interest for conflict. They want to argue the whole time. Some people will just say, well, look, I'm not dealing with this, and we're done. So there's a French term. My wife is French, and there's a term that they have called filet à doigts, and it means there's enough craziness for two. And that's how you feel after you meet with patients who are dealing with this very serious condition. And you're like, I don't want to go down that path either right now with you because I don't have the time or energy or the training or experience. So it is real and it is growing, and we need to be more prepared for it.
Can you be more specific to the conditions that you see in your practice that would qualify as psychocutaneous?
So fortunately, we don't have a huge amount of diagnosis. Each one of them by itself is going to be a lifetime of study. But I can just give you right off the bat, the most common is delusions of parasitosis. That where you have a hallucinatory symptom, or we call it formication, where they have a real sensation of crawling, biting, or stinging in their skin. And they have now decided that this is a result of bugs that live in their skin. I remember one time being called to the hospital where I was doing privileging, and they said that he's suffering from terrific itching. Well, I wish they had told me more, but when I got there, I found out that the patient believed he had insects that were living in his skin. But I said, I don't see any. He says, well, they hear you coming, and they fly back inside my skin. They live there, and they make me miserable. And then when you leave, they fly out. Well, I've had plenty of people who come in with their family members, and the family member is totally given into this delusion themselves, where insects are living in their skin. Now, here's the thing. Insects, so to speak, like skin mites, do live on the surface of our skin, and we can have scabies, which live under our skin and are treatable. But these stories are much more elaborate and exotic, and these delusions of parasitosis really can be quite amazing. There was a drug company that came out with an eczema product a few years ago, and they showed the commercial where the person goes to the sink and ants were crawling on her skin. They were trying to illustrate that the sensation of bad eczema is like ants biting and crawling on your skin. Well, oh my goodness, all of us in dermatology were inundated for months afterwards, people going, I want that medicine where bugs live in your skin. And we're like, no, that doesn't have anything to do with it. I look for substance abuse. It is sometimes associated with methamphetamines, schizophrenia. I've seen it with people who have other obsessional states, bipolar. We also see it with severe depression and other anxiety disorders. It can also be affiliated with certain history of suicidal attempts. So, all of a sudden you very quickly move from dermatology to psych. And so, delusions of parasitosis is one. Very quickly, dermatitis artifacta is another one, or factitial dermatitis, we sometimes call it. And that is a really interesting one because a lot of teenagers have it, and this is where they'll use like a foreign object, even their fingernails, to make a lot of cuts or lesions. They're kind of creative and bizarrely shaped and oddly distributed on the body. I've seen actual patterns. This has to do with some kids who have some real dissociative disorder in their body. This dissociation is where they're kind of floating outside their body. Their consciousness is different. Their identity or perception of reality is kind of moved away from where the rest of us are. It can be PTSD related. We look for what's called the Mona Lisa patient, where they just kind of sit there with this kind of smile. The parents are upset, but they seem kind of unaffected and serene. And the family often thinks that we're the ones that are nuts in healthcare. Why aren't you taking this seriously? They can go through biopsies, chest x-ray, blood work, doesn't show anything, but they're doing that to themselves. That's called dermatitis artifacta. We also see trichotillomania. That's a French term of pulling hair, very common in young females between ages 12 and 16. They think it's alopecia areata, where it's a, autoimmune disorder that's affecting their hair, but they're pulling it. And some of them will do trichophagy, where they're eating the hair. Trichophagy is where they pull the hair and then they eat it. And it's really tough. It could be tinea capitis, and they're never honest. They don't tell you that's what they're doing it, but they need counseling, and they can pull on their eyebrows, their scalp. I've seen kids pull ear hairs, nose hairs, and parents are wondering why they get these, constant infections. Another one is, of course, dysmorphia. I don't have Instagram, but I hear that Instagram is a place where you can gather together and put on fantastic pictures of yourself. You can even adjust it yourself so you don't look a certain way. Maybe if you're a female, you can have larger breasts, or men, bigger pecs. But body dysmorphia, that's not how people really look. And it's this preoccupation of a non-existent or kind of a slight defect in appearance. And that's why you see women getting these huge collagen injections in lips, or, I've had 15 surgeries. I want to look like Barbie or Ken. And there are people like that. And it gets really frustrating for us because, you have to be ethical. I can't just keep cutting on a person or agreeing with them that there's something wrong. look in the mirror and they see something terrible. We see that a lot with tattoos, and also, they want to tattoo their eyeballs or slit their tongues, cut their ears, and we're seeing at an earlier and earlier age. So these are issues that have to do with mind and body, and we are seeing more and more of it.
What are some of the more helpful and therapeutic responses for these patients, and how successful are they?
Everything that I tell you in response to that question, I want to first give credit to Dr. John Koo. John Koo, last name spelled K-O-O, he is one of the most amazing individuals that we have in American healthcare today. He's of Korean background. He is a friend of mine. I got him on Fast Dial on my phone. We have traveled in an open Mustang, the island of Kauai in Hawaii, and just talked like two good friends about the conditions that and experience that he faces on a regular basis. Dr. Koo is remarkable because he's not only a Harvard MD in dermatology, he is also a Harvard MD in psychiatry. So where in the world do you meet a person with such experience and intelligence like himself? And so much of what I'm sharing today has to do in my conversations with him. Dr. Koo also, besides blending both psychiatry and dermatology, has given really good practical ideas in conversations with him. And I have his complete permission to share these ideas as well. He's written many, many articles. So once again, let me give credit where credit is due. And Dr. Koo will tell me, or has told me, and I'm sharing with others, when you meet a patient where you have a suspicion that this is delusion of parasitosis, or they're experiencing high levels of anxiety and it's reflecting in their skin, he said, be cheerful. He said, remaining cheerful and even-keeled is more important than prescribing. You want to connect with the patient, and that first visit is going to be validating the patient, not challenging their reality. It's easy to say, look, this is not true. We think that being hard on the patient is going to be therapeutic. It's not. It just makes them more combative and close down and want to go to the next doctor. You want to do doctor shopping. And that's wrong because it's very expensive. And we're just basically saying, you're not important to me in my time right now, and I'm not going to spend what is required. So I am very, personable in my encounters with them, and I will sit on a stool that is eye to eye to them. I'll sometimes pat them lightly on the knee or the shoulder, and I'll say things like, I'm sure this has been very challenging, or I'm sure you don't want to live like this, and I know you came here today because you want to become better, don't you? And so in my mind, I already have structured the visit once I determine that this is of a psychocutaneous nature. And I know that I'm not going to get anything done that day except getting them to trust me. The other thing that I do in that first visit is I also am honest, and I say, look, let's try to honestly rule out a background issue. It has happened a few times where I find a kind of a subclinical level of psoriasis or eczema, or one time it was staph, and it's kind of low-level colonization of staph. And, hey, we treated it with antibiotics, the itching went away, and they felt much better. Dr. Koo also recommends that we give patients at least 3 microscope slides and give them covers and say, look, I'm giving this to you because I care about you, and I want you to scrape when you see anything suspicious into this microscope slide. And I have had over the years, a number of fascinating encounters and stories. I wish we had the time in this podcast to tell you, but one time I walked into a room, and the room was totally dark, and the man was standing completely naked on the chair and holding a cap he had made of aluminum foil. And he said, don't turn on the light, he said, because if you turn on the light, it's going to activate the bugs in my body. And I'm trying to also prevent with this aluminum foil, and you've heard the phrase, wearing a tinfoil hat. Well, it was true. And he had aluminum foil on cardboard covering over his head. He said he didn't want any fluorescent light to activate the bugs in his skin. Well, I gave him a gown after the initial surprise, and I had him sit down, and we did not have the light. We had the door cracked open slightly with a curtain, and we had a really great conversation. I have been taking care of this man for 15 years, and he comes in once a year. I write him a placebo cream. We talk to him very nicely, and I think there are people who might be upset with me and say, that's unethical, that was immoral, that's wrong. It's just a simple, non-steroidal cream. Whenever he has an itch, he puts it on. He's satisfied that it smothers whatever bug. The family is happy. His wife is happy. His children are happy. He's able to function. And, that sometimes is what it takes. 15 years, and he's been good. By the way, a book I recommend for helping understand everything I'm saying is Dr. Stephen, that's spelled Stephen, middle initial E as in Edward, Wolverton. And Dr. Wolverton's comprehensive dermatologic drug therapy book, the latest edition is still 2012, has been fantastic in giving us ideas on how we can treat people medically as well, or I should say with pharmacology. So I establish a patient rapport. I'm very thorough in my exam. I try to make sure that there's no other differential. I try to engage family members so everybody understands where we're going. And Dr. Koo relies a great deal on a pill called Pimozide. Pimozide is sold under the brand name ORAP, O-R-A-P. But Pimozide is an antipsychotic drug, and he'll give 1 milligram by mouth daily for a week and increase, if needed, by 1 milligram each week until this agitation with delusions of parasitosis in particular is achieved. And if you can reach that 3 milligram, they're happy, not combining therapy with anything else, then do that for about 6 months. And you can slowly taper down if you need from there and see how they're doing. That's if they're open to the treatment after you've developed a relationship. So Pimozide tends to be a very highly selective dopamine D2 blocker, and it's the most studied and reported drug in the clinical research for delusions of parasitosis in particular. But I tell people, we're going to work this out. We're going to relieve the stress. I care about you. I didn't find any parasites today. I'll look at whatever you bring me under the microscope, and I want to give you a medication that has helped other patients as well.
Can you name some of the other conditions that you've come across in your experience?
One thing we have to remember is that we can have common dermatological conditions that can cause stress and anxiety and are not technically psychocutaneous. Let me give you an example. If you have untreated atopic dermatitis or eczema, and the person scratches and picks all the time, that habit tic can lead to infection, ulceration, and a kind of a vicious cycle of releasing histamines. And histamines, as we know, when you scratch on the skin, cause more histamines, and they're all itchy. Mosquito bite, for example, is a classic example of a histamine release. So I would recommend that all providers don't go right to the psychocutaneous, but take a look and see if it's not maybe something more common that can come across as psychocutaneous. For example, what if I have a 16-year-old girl that suffers from horrific acne, right? It's nodular cystic. The parents come in and they say, look, it's just acne. It's not cancer or melanoma. They don't seem to be really concerned about it. But I see the girl that she's got her head down. She covers her face. She's thankful for the mask. She doesn't want to even remove the mask these COVID times for me to see her face. I turn to the mom and I say in front of the daughter, I'll say, you know what? I want to tell you that while this is not melanoma or cancer, I think that, Kelly here, or whatever her name is, seems to be pretty distressed about it. Kelly, how do you feel about this? Well, I don't like it. Well, Mom, we can do things about that to help her. And it's interesting how many times we do improve someone's outlook on life. I'm Ukrainian, and that was my first language. I want to say nasty. And nasty literally means that how your outlook on life is overall, your attitude, just by treating something that was affecting them emotionally. I one time had this young man come in. He had a hoodie on. and he had it kind of closed up. He had his head down, and he was about 16. And the mom said, he never lets me look at his face or his back or chest. And, he's just always seems to be in his room, doesn't pay attention to his friends. He's not joined any clubs. And I go, let's take a look. And he had pretty cystic acne. So I put him on a product that was designed to address that. And about 4 months later, the mom came in and she was wagging her finger at me. And she said, you've created a monster. I said, excuse me? And she said, well, my son now, he's always on the phone. He's always talking to people. Girls are coming over. He's gone in the evening because of sports, all because his face cleared up and he feels so confident. And, the light went off, a bell rang in my head. And I was like, exactly. That's the mind-body connection, the psychocutaneous, the how our mind is in our skin. We improved his skin, and all of a sudden, he's belle of the ball. He's the king of the class. And we need to address this more and more to see how it affects both mind and body. So acne, eczema, psoriasis, lupus, other conditions that come across can have a psych implication as well.
Let's bring up a controversial topic, Morgellons disease. What is the history of that diagnosis and the arguments for and against it?
Well, you brought up a real can of worms with Morgellons. I'm sure that most of us in healthcare have heard of this term. Morgellons was coined by a British physician by the name of C.E. Kellett, Kellet, and he publishes this paper in 1935 on a condition that he's not sure what he's seeing. And Morgellons is an old French term. It means little flies, literally little flies, Morgellons. Back to French today. And in 2002, a woman by the name of Mary Leitao found the Morgellons Research Foundation. So what happens is we find this Morgellons as a diagnosis, so to speak, to explain what a lot of people have been frustrated with. And it was mostly delusions of parasitosis. Now, I really want to make an interesting point here. 2002, when the Morgellons Research Foundation comes up, this is also an interesting time because the internet is really kicking in as well. I still remember the internet in the early 90s when we had those 14.4 and 28K, little attachments to our computer to download. I remember once wanting to read something about the Beatles, and I did a download for a photograph, and I went to lunch, and I came back, and it was almost completely downloaded. That's how slow things were. But in 2002, we start having the internet, and people are doing podcasts, and we have people organizing, and they're like, hey, I'm also suffering from something. The doctors have told me I'm crazy, that it can't really be anything except in my mind, but I am itching, I am burning. And the Morgellons Research Foundation takes off. Senators Dianne Feinstein and Dick Durbin contacted the CDC in 2005, and they requested an investigation on Morgellons. That's how big it got. Like, what is this condition that people come into dermatology and psych with, and it's itching and burning, and nobody knows what it is? Well, the CDC then, in June 2006, a year later after Feinstein and Durbin contacted the CDC, came up with what's called the Morgellons Task Force, and it first met. And they wanted to know what in the world was happening. Well, guess what? They found out that there was no evidence for claims that insects were living in anyone's skin. And in November 2006, just months later after this task force meets with the CDC, the American Journal of Dermatology publishes that Morgellons is not a parasitic infection, but it's a psychological disease that requires pimozide, which is what we were already talking about earlier. And then in March 28th, 2007, the CDC removed the page Delusions of Parasitosis from their website section on parasitic diseases. So this was a huge blow to those proponents of Morgellons disease. You can still get a calendar. If you go to their website, which is kind of run through Oklahoma State University, they're now saying that it's not insects, but maybe it's fibers that are protruding from the skin. Well, again, that we don't really have any evidence for that. So the argument for Morgellons is if providers would only not argue and try to listen and conduct thorough exams and not refer us immediately, that maybe, in fact, we can get to some resolution. The argument against Morgellons is that, look, it's an uncategorized disease. There's no cause. You're assuming that there's maybe bugs, but we're not finding any. So we'll do the best to help you with the symptoms. And there's a very small group of dermatologists that just put up their hand and say, look, this is psych. I'm not dealing with it. You're going off for an evaluation and treatment.
Is there an official statement from anyone in authority in dermatology on Morgellons, or is it an open and shut case?
Well, I said earlier that, Morgellons really came out like a socially transmitted disease of mass delusion. Do you like that phrase, anyone? And it kind of exploded with the rise of the internet. I'll say it again, a socially transmitted disease of mass delusion, thanks to others amplifying, on different websites like, yeah, that's what I'm experiencing as well. And it's got to be, I'm glad I'm not the only one. Finally, the American Academy of Dermatology in November 2006 came out with the following editorial. And it probably is a good statement to read word for word. But essentially it says that we need to allow patients the validation of using the term Morgellons, but at the same time prescribe the antipsychotic Pimozide or risperidone, which I'll pause for a moment and say we did not discuss in this podcast, but just we're trying to bring up some awareness. Anyway, going on with their official statement, it says, acknowledge to the patient that they suffer from, quote, Morgellons, unquote, but then suggest treatment to relieve the symptoms with antipsychotics. We emphasize the importance of clarifying to all delusion of parasitosis patients that their condition is not a result of an infectious agent. However, we find that the term Morgellons is of paramount importance in establishing patient confidence and developing patient-physician rapport throughout their care. So if they want to use the term Morgellons, and unquote, and if they want to use that term, it appears the American Academy of Dermatology is saying, then we need to go ahead and use that. There's just nothing unethical about that, if that's where they're coming from, and if that's important to them. So, it's not an open and shut case right now. It's happening in that people are coming for help, and we need to be available to work with where they are.
Do you have any final thoughts?
My final thoughts on this is that we be prepared. As providers, we need to have at least awareness for understanding that when this patient comes, what to do. I like being able to be prepared and taking control of the situation where I am. It's cheaper for the healthcare system because if you have to send them out, that's another copay. It's also, you can lose people in between referrals. Also, I find that learning as much as I can and attempting from patient to patient to finesse my presentation and assessment is better for our patients as well. They'll gain confidence. Third, I would say always include the family. Be sure to have family members present. If they come alone, ask if there's family and if they can come also, because that could be your best ally. And finally, I would say be patient. Just really be patient. And, if you went into healthcare, I think you're probably a person that cares already. So this is going to really put that caring to a test, and you'll find out what you're made of. And you'll be better prepared for the next patient as well.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.